Welcome back. You have already listened to the larger presentation and where all the skills that the AMC is assessing us for this exam. So this next is more about the specific things about the history taking in this case. And we will quickly go through the things that you need to ask. And it's pretty much explanation and exploration of the same information that I shared in the videos about the case approach sequence. So let's get started. So we start being assessed when we get the notes and we have the 2 minutes reading time, because that's when we get the information to start our thinking process and to prepare how we're going to behave and of course perform with the examiner and the patient. So those 2 minutes are very important, and it's essential that you are in the moment, you breathe and you are calm, because if you stress at the last minute, you are a mess, it's all over the place, and you won't use your time wisely. Always read carefully. As I mentioned in the previous workshop, you can miss important information if you don't read the whole sentences and look at what you are being asked. So by the clinical notes that you get, you can understand where the setting is, who is your patient, and what's the presenting complaint. And with that information alone, your brain can start working on what's going on and have a plan. So ask yourself, if you are in the clinic, in a hospital, in an emergency department, what's the age and gender of the patient? That will straight away focus on kind of the history. And the same with the presenting complaint, you will direct your efforts to asking some questions, and also in the examination, you will focus on certain, getting certain corroboration of certain physical signs. Always ask yourself, is this an emergency? And exactly what are my tasks? And or answer them in the order that you are being asked. With the symptoms in mind that you get from the notes, ask the patient to gather information and to explore best what's going on. Do not close your mind to, I think this is the diagnosis and I'm going to confirm this is the diagnosis, and just be fixed, but be open-minded and focus on what the patient, with the clinical notes, what the symptom is and what the patient is going to tell you. And of course, this is a management serious case or life-threatening situation. You need to start with the management before talking to patient or getting in history. So introducing yourself and saying who you are, how can I help you? And this is more the time where you open, ask the open questions and let the patient talk to you. If you are going to see the patient for a follow-up, looking at results and focus, say your task is only counseling, so it's more about to frame what you're going to do. I understand that you are here to discuss this, or what's your expectations if you're going to be talking about the counseling and explaining, say, breaking bad news or something. So just clarify what the consultation, how the consultation is going to evolve and what they can expect. If a patient is coming to ED, so as I say before taking history, you could quickly check for the ABCD. And of course, ask if they have the pain, offer the painkillers, always checking that they don't have allergies. And you can say, I will offer some painkillers. The same if the patient, of course, is unconscious, you can get permission to do some tests, see if there's a family member or a friend that you can talk to, but first to start the management. This is just a quick guide of the Glasgow Coma scale, but there's some scenarios that request you to know it, and of course to be able to assess and and see what the number is based on information provided by the examiner or the case notes. One thing that is important and we cannot underestimate is the confidentiality statement. It's very important for generalized symptoms, medicine, surgery, when we don't know what's happening and it's very vague, fatigue, fever, or weight loss, for example. All the women's health, especially teenagers, and as well mental health. So you want to frame, and before you start, be clear with the patient that everything that you talk there is going to be confidential, remains there. However, if the patient is in danger or you need to, someone is in danger or you need to talk at court, you will be able to disclose information. And some tips for history taking is try to look relaxed. I know you may be nervous inside, but you don't want to show your nerves. Allow for pauses. It's okay to have some silent moments and check that you understand what's happening and the same patient is clear. Make sure that it's not very flat, but change the tone so it's more dialogue. And we're going to look at the history. So open questions, same as we looked before. So let the patient talk most of the time. Keep going, help them to talk and expand. The more they expand, the better information they will give you. That will help you to move into the next tasks. So what else? Clarify, tell me more, and then summarize to make sure that you got it right. Past medical histories, we need to always check or what else is going on, or history, surgical, psychosocial history, medical cases as well. Some patients, all the diagnosis or all the information will come from a travel or a occupation base. So it's all about making sure that we don't miss these opportunities to ask when we first collecting the history, because you don't want to be jumping from examination or differentials to, oh, I forgot to ask this. So it's good to keep in order and to focus on everything that you find relevant in this case. You may have heard about the Socrates. It's great for presenting symptoms, and you can break it out and explore in detail what's happening, what's the size affected, when and how it started, character of a pain or a symptom, radiation, if it goes away, what's alleviating, what's a exacerbating factor, or how long, when did it first start, and also how bad it is. Similarly, we have Sortsara, that is about pain, but I think with the Socrates, you can also say the pain well. So work with whatever feels better for you, and you can just get in your head easier. So the same, the severity, onset, radiation, termination site, if it's going somewhere, aggravation, relieving factors, and other symptoms that are associated. So just take time to learn and to process the information. After the history of presenting complaint, you want to do a system review and look for the associated systems and see what else is happening to have a better understanding and not to miss important information from the condition that they are currently experiencing. So this is quite a list. You won't be able to ask all, and you don't need to. It's more about what's relevant to the patients based on the case's notes and what the patient has told you. Of course, it's all about the clinical reasoning and the diagnosis that you are formulating in mind. And by asking this, you will be able to rule things out or move towards clarifying a definite diagnosis. With the medical history, you want to ask, yes, adults in general, if they have any previous conditions, admissions to hospital, surgery, if they have been to the specialist lately, what management is going on, screening for breast cancer or colon cancer if there's relevant history. Those are the general things that you want to ask as well. Immunizations, however, immunizations is more important to kids at this stage. For kids, we have the BINs for us to remember. So it's all about their birth, if there was any issues, if they were born at term, mode of delivery, if there were any problems, stay in hospital, any prenatal events, the same immunizations up to date. How is the diet and nutrition development? If the mother thinks that the kids are doing the things that they should be doing for that age. And if they have noticed any issues related to speech, vision, and hearing. For women, we have the 5 Ps. That is more about, yes, all women who have their menarche, and most importantly, are with active sex life. So you want to check if there's any possibility that they are pregnant. That's always a question that we cannot forget. What age they will have the first menstruation, how is the cycle, if they had any pregnancies, and how many children and deliveries, when was the last period, of course, if they have a regular partner or not, how they do the family planning, any history of sexually transmitted infections, and pap smear, when was the last one and how was the result. For teenagers, they have here the Gardasil vaccine for HPV, so we want to ask if they had that at the school. Pregnancy, is important to check for the blood type, and of course check how long they are in pregnancy, if they feel the baby, if they have any symptoms that can point towards preeclampsia or diabetes, and if they have any bleeding, how much they are in the system, regular antenatal care. And for postmenopausal women, there's the 4 Bs, 2 Ps. So always include in your, this is more about systems review, probably, or just history. Yes, not system review, but part of the history, check if there's any problem with incontinence, yes, the bowels, breast, pain, lumps, and bones. This is the last B is missing. Okay, so fractures. P, prolapse, or postmenopausal symptoms. That could be a cause of complaint or just something else that you want to investigate. So it's always asking the history and keeping some comprehensive information about the patient will look good, and it all depends if time allows and how much information you ask. So be very clever with the time. Family history is just a quick comment. If there's any relevant medical history within the close members of the family. Of course, if it's relevant to today's complaint, that is more if someone is traveling and all the family is sick, poison, or if a child is sick with group, we want to see who else is sick at home, mental illness. So it's just one short comment, but it's important that you do it. Psychosocial history could be long, but the same. It could also be small statements or questions about asking the stigma, smoking, alcohol, drugs, medication, and also allergies. Checking, understanding more what's the social situation, who else is at home, what's the stress factor, if the moms are doing well with newborns, if they are coping, if the kid is being bullied at the school, bullying, adolescent, if there's any, the same, alcohol, depression, drugs, sex, they are practicing safe sex. So it's a lot, but having a patient, it means that we want to look at the whole life. So it always is good that we cover this part. This psychosocial risk assessment is very good for mental illness, and of course, depending on the presenting complaint, if you think that someone is self-harming. So check if the patient is depressed as well, if they have made any plans or they want to end their life, and how much further they have progressed with this. And of course, the occupational history. Some patients will have a condition that is very related to their occupation and of course the exposure. So you need to know what they do for a living. Travel history will indicate as well the risk factors or lead you to a diagnosis of condition that you may not have explored if you didn't know that they were gone overseas or in a specific place where there's some diseases, or just they engage in activities that are risky as well. So to conclude, some patients will be very easy, cooperative, and they will get the information that you will get the information what you want. However, some patients can become aggressive and uncooperative. Always check or think if there's alcohol intoxication, drug use, or something else going on, like severe condition like a tumor, or after a fall, that could alter how the patient behaves. And also if the patient is self-harming or going many times to the same doctor, is this happening? What else is underlying? So it's all about understanding what's going on and the why patient behaves like that. Always to keep in mind the nonverbal communication and the emotions, recognize what's going on from the patient side. I know this may be frustrating, or I know makes you feel angry. This might be overwhelming. You seem sad. I understand. So I'm here to support you. Try to name what's going on and to deal with the issue with respect. This is all about when you are doing counseling and when you are required to talk a lot. So just engage in your language, like with the verbal, and as well show empathy and show that you care and you understand what they are going through. Thank you for watching this part. So this is all the history, as I believe is one of the most important parts, because you will collect all the information that you need to make your clinical reasoning and to help the patient. So I have a lot of short audios for different topics, history, just scripts, what to ask and how actually is in real life, or when you are doing a 2 minutes history, how can you do it without presenting complaint. There's a lot of information in my full clinical summaries if you are interested. And for now, I leave you to go to the next of these workshops. We keep going. Thank you for watching.